Good morning, dear learners, and welcome to the MOOC on Economics of Gender and Development. And we are in week 10, and this is the last module of week 10. This is module 34 on gender and reproductive health Indian context. So, just like in the previous discussion, we discussed these things in the context of global. So, here we will be discussing the same issues in the Indian context. So, just like the standard definition in India as well, just like in the global definition, reproductive health is conceptualized as a state of complete physical, mental, and social well being in all matters related to the reproductive system, implying that individuals possess the capability to reproduce and the freedom to decide the timing and frequency of doing so. So, as a signatory to international frameworks like the Sustainable Development Goals, India is obligated to ensure universal access to sexual and reproductive healthcare services and reproductive rights. Historically, the Indian approach was dominated by population control demographic targets, but it has gradually transitioned towards a right-based paradigm that addresses the needs of individuals across their entire life cycle. Now, when we see the reproductive healthcare needs between unmarried versus married women, we notice that the reproductive healthcare landscapes in India is starkly bifurcated by marital status, with policies and social norms prioritizing married women while often marginalizing or stigmatizing the needs of unmarried women. So, for decades, married women have been primarily target of India's family welfare program. Currently, approximately 72% of currently married women in the age group of 15 to 49 years have their demand for family planning satisfied by modern methods. However, the burden of contraception remains heavily gendered. 38% of women use sterilization as a method compared to only 0.3% of men. The median age for female sterilization is remarkably low at 25.7 years, reflecting a trend where women complete their desired family size early and then opt for permanent methods due to lack of support for long-term spacing methods. The maternal healthcare needs of married women are addressed through flagship schemes like Janani Suraksha Yojana (JSY) and Janani Sishu Suraksha Karyakram (JSSK), which provide cash incentives and free services for institutional births. While institutional births have risen to 88.6% nationally, married women from marginalized communities still face challenges, including poor quality of care in understaffed public hospitals and harassment for informal payments. Furthermore, married women face emerging health crises such as unnecessary hysterectomies, particularly in states like Andhra Pradesh and Telangana, often performed in the unregulated private sector. Now, looking at the healthcare needs of unmarried women, we see that unmarried women in India face profound barriers to reproductive health, primarily rooted in social stigma and a cultural script that equates reproductive health solely with family planning for couples. Thus, while the Medical Termination of Pregnancy (MTP Act), as we called it, was amended in 2021 to allow unmarried women to access abortion due to contraceptive failure, a significant legal milestone access in practice remains still difficult. Many providers still hold biases or fear legal repercussions, often conflating the MTP Act with the PCPNDT Act, that is Preconception and Prenatal Diagnosis Technique, which restricts access to safe services for single women. Research indicates that unmarried, sexually active women have high unmet needs for modern contraceptions. While more than half, 55%, use some method, awareness and use of the emergency contraceptive pill, ECP, remain low. Less than 1% of women sampled in national surveys had used it. Furthermore, unmarried women often underreport gynecological morbidities such as irregular discharge of fibroids due to the perception that these issues are linked to sexual behavior, which is considered taboo outside of marriage in our society. So, this stigma extends to menstrual health. Although use of hygiene protection has increased to 77.6% among youth women, many still face discriminatory practices and menstrual taboos within the household. Now let us make an overall analysis of progress India has made since NRHM and also in the MDG or SDG period. India's progress in reproductive health since the launch of the National Rural Health Mission NRHM in 2005 and the transition from the Millennium Development Goals to the SDGs, Sustainable Development Goals, has been substantial yet unevenly distributed. And in the earlier module also, we have already discussed that the most visible success has been reduction in the maternal mortality ratio. For example, in 2004-06, the maternal mortality ratio stood at 254 per 1 lakh live births, and by 2018-20, this figure has dropped significantly to 97. And this progress is closely linked to the NRHM strategy of incentivizing institutional deliveries through JSY, Janani Suraksha Yojana, which transformed childbirth from a home-based event attended by relatives to a hospital-based event. So the introduction of a dedicated cadre of village health workers, the ASAs, accredited social health activists, and a free ambulance system has bridged the first two delays of deciding to seek care and reaching a facility. Now let us look at the infrastructure and systemic challenges. But despite these gains we have already talked about, the health system remains fragmented. While specific vertical programs like HIV/AIDS, TB, and maternal health have seen funding, the general primary healthcare system remains underfunded. And in the previous modules, we have seen what percentage of funds, budgetary resources in terms of GDP, India invests in health. And for instance, central government's employees enjoys high per capita health budgets, while the general population relies on a system that spends 6 times less. Furthermore, the quality of care, which we may call the third delay in the delay model, remains a critical bottleneck in India. And this 3 delays model we have already discussed in the previous module. Now, analysis of NFHS, National Family Health Survey, 5th round data show that while 94% of women received some antenatal care, ANC, visits, only 1 in 5 received the full adequate quality of services mandated. The Sustainable Development Goals period has brought a focus on the gendered nature of health. So when we look at the gender equality and nutrition, we will see that India's sex ratio at birth has seen a marginal improvement from 1991 women per 1,000 men in 2015-16 to 1,020 in 2019-21. Though child sex ratios remain skewed due to persistent son preferences in some of the states in India. However, nutritional status remains a regression point. The prevalence of anemia among women aged 15 to 49 has actually increased from 53.1% to 57% between National Family Health Survey 4 and the 5th rounds. So this anemia epidemic reflects deep-seated gender inequalities in intra-family food allocation and the cumulative burden of frequent pregnancies. Now, let us make a comparative analysis between NFHS 4 round, which was conducted in 2015-16, and NFHS 5th round, which was conducted between 2019-21, to understand how India has made progress in some of the health indicators in the recent times. And we can see that the following tables, 1 to 5, as you will see, provide a comparative analysis of key health and demographic indicators between the NFHS 4 and NFHS 5th rounds. Based on the national level data, we can see from the reports. So table 1 highlights improvements in basic living conditions and population metrics across India. So in table 1, we will see the data of NFHS 4 and NFHS 5 for sex ratio of the total population, females per 1,000 males. It was 991, it has increased to 1,020. Now sex ratio at birth, females per 1,000 males, it has increased to 919 to 929. And children under 5, whose birth was registered, it has increased to 79.7% to 89.1%. And population living in households with electricity, it has increased from 88% to 96.8%. And household using an improved sanitation facility has increased from 48.5% to a quite good level of 70.2%. And household using clean fuel for cooking has increased from 43.8% to 58.6%. And households covered under health insurance or financing has also increased from 28.7% to 41%. In table 2, we see the family planning and mortality rates. Here we see that infant mortality rates, which is measured in per 1000 live births, has come down from 14.7 to 35.2. Similarly, under 5 mortality rates also has come down from 49.7 to 41.9%. And regarding current use of any family planning method has increased from 53.5% to 66.7%. And current use of any modern method has increased from 47.8% to 56.5%. Similarly, total unmet need for family planning has come down from 12.9% to 9.4%. And total fertility rate, that is children per woman, has also come down from 2.2 to 2%. So this table 2 indicates a decline in mortality rates and a significant increase in the adoption of family planning methods. And in table 3, we see the maternal child health indicators. Here we see the mothers who had ANC checkup in the first trimester has increased from 58.6 to 70%. Mothers who had at least 4 ANC visits has increased 51.2 to 58.1%. Institutional births we already indicated has increased from 78.9 to 88.6%. And mothers consuming iron and folic acid (IFA) tablets for 100 days or more has increased from 30.3% to 44.1%. Similarly, postnatal care within 2 days of delivery also has increased from 62.4 to 78%. So we see that maternity care indicators show consistent gains, particularly in institutional births and antenatal care attendance. Similarly, we see in table 4 nutrition and anemia trends. Here we see women in the age group of 15 to 49 years with BMI below normal. Similarly, women in the age group of 15 to 49 who are overweight or obese. Then we also see anemia among all women in the age group of 15 to 49. Anemia among children, age group of 6 to 59 months. That is from 6 months to 5 years. And anemia among men between 50 to 49. So these data are given for NFHS 4 and 5th rounds. And here we see that table 4 indicates that while nutritional deficiency, low BMI, declined, India saw a rise in the triple burden of malnutrition, including rising obesity and anemia. And in table 5, we see the women's empowerment and education indicators. Here we see women with 10 or more years of schooling, women having a bank or savings account, then young women in the age group of 15 to 24 using hygienic menstrual protection, and ever married women experiencing spousal violence. So here we see the data, and here for the social indicators for women, it shows a marked improvement, particularly in financial inclusion and schooling. And these data are from the National Family Health Survey, 5th round data. So from these tables 1 to 5, we can see that significant advancements have been achieved in India's demographic, health and social indicators, alongside persistent challenges in nutrition and anemia. Let us consider some of the facts as shown in the below. With regard to population and household profile, we see that living conditions for Indian households have seen substantial improvements. Access to electricity has rose from 88% to 96.8%, and the use of improved sanitation facilities increased dramatically from 48.5% to 70.2%. The sex ratios of total population shifted from 991 to 1020 females per 1000 males, and the sex ratio at birth also improved from 919 to 929. Furthermore, birth registration with civil authorities increased by nearly 10 percentage point to 89.1%. Similarly, we also see the things in family planning and mortality rates. India has made consistent progress in reducing mortality, with IMR falling from 40.7 to 35.2, and the under 5 mortality rate declining from 49.7 to 41.9 per 1,000 live births. And concurrently, the total fertility rate reached a below replacement level of 2. And contraceptive prevalence rose significantly from 53.5% to 66.7%, while the total unmet need for family planning dropped from 12.9% to 9.4%. Similarly, in maternal and child health, we have seen that meta-Etica indicators show a positive trajectory, and mothers receiving an antenatal checkup in the first trimester increased from 58.6% to 70%. And those attending at least 4 ANC also has increased to 58.1%. And institutional birth saw a major increase, reaching 88.6% compared to 78.9% in the previous rounds. Additionally, the proportion of mothers receiving postnatal care within 2 days of delivery improved from 62.4% to 78%. And with regard to nutritional anemia, we see that while the percentage of women with a below normal body mass index decreased from 29.2% to 18.7%, there was a corresponding rise in overweight or obesity, increasing to 24% for women and 22.9% for men. And most concerning is the stage in anemia prevalence across all groups. For women, 53.1% to 57%, and children, 58.6% to 67.1%, and also for men, 22.7% to 25%. And with regard to women's empowerment and education indicators, we see that social indicators for women showed strong gains. The percentage of women with 10 or more years of schooling rose to 41%. Financial inclusion saw a major leap, with women having and using a bank or savings account jumping from 53% to 78.6%. And additionally, the use of hygienic menstrual protection among young women increased by 20 percentage points. And finally, reports of spousal violence saw a marginal decline from 31.2% to 29.3%. So here the main concern for India is, why is anemia still very high? The increase in the prevalence of anemia in India, which rose from 53.1% to 57% during this NFHS 4th and 5th round for women, and from 58.6% to 67.1% for children, and driven by complex interplay of biological, socio-economic, and environmental factors. So the following are the specific reasons studies have shown for this increase and its persistence. The first is the dietary and nutritional factors. Studies have shown that major dietary and nutritional factors include: first is the poor dietary diversity. Indian diets remain heavily cereal-based, lacking sufficient intake of animal-based proteins, meat, fish, eggs, milk, and variety in fruits and vegetables. The other thing is iron deficiency. This remains a primary cause, estimated to be associated with half of the global anemia cases. And next one is the lifestyle shifts. There has been an overall unhealthy shift towards consuming low-cost processed foods and a sedentary lifestyle, leading to a triple burden of malnutrition where rising obesity coexists with rising anemia. And last but not the least, the factor is restricted access to protein. Political and religious backlash against certain foods, such as beef, a sheep protein source, or the inclusion of eggs in school midday meals, has deprived many marginalized communities and children of essential nutrients. The other set of factors are the socioeconomic and gender dynamics. And important socioeconomics and gender issues include here. First one is the intra-household food allocation. Deep-seated patriarchal norms often dictate that women eat last and least, with men and children prioritized for more expensive and nutritious food items during times of shortages. Another issue is the economic distortion inflation. Rising food inflation eats into real incomes, forcing poor households to reduce food intake or skip meals. Furthermore, fuel inflation increases women's time poverty and drudgery as they revert to collecting firewood, which negatively impacts their health. Then another factor is the lack of autonomy. Many women lack of autonomy to make independent health-seeking decisions or control food choices within the family. And there are also the factors like health and environmental factors. And these factors include, first one is the infectious diseases. Chronic infections, hookworm, and other helminth contribute to anemia. Malaria specifically, the P-Vivax variant is also a significant cause, as repeated relapses lead to long-term anemia. Then sanitation and water. Poor access to clean drinking water and sanitation leads to frequent infections that hinder nutrient absorption. And another issue is the frequent pregnancies. A lack of nutritional recovery time between pregnancies depletes a woman's iron stores. And finally, there are certain intergenerational and systemic issues. And these issues include the intergenerational cycle. Malnourished adolescent girls become anemic mothers who are more likely to give birth to low birth weight babies, perpetuating a cycle of nutritional deficiency. Then here also comes the issue of reporting bias. One potential reason for the statistical increase reported in recent surveys may be greater awareness, leading to more frequent reporting of symptoms. And finally, the issue also comes from policy gaps. While schemes like Poshan Abhiyan aim to reduce anemia by 3% annually, implementation is often hampered by a lack of updated population data and the exclusion of vulnerable groups, such as married women who move to a new household and are not automatically added to ration cards. Now, let us undertake a state and regional level analysis in India. What has been the trend of progress across states and regions? So, we shall now make a state level comparison of key reproductive health and empowerment indicators demonstrating the progress India has made between NFHS 4 2015-16 and NFHS 5 2019-21 rounds. Let us begin with progress in maternal health care. Maternal health indicators, particularly institutional births and the attendance of at least 4 antenatal care visits, show significant improvements across most states, as we have already seen, although the quality of care remains a regional concern. And we see here in table 6. So here in table 6, we saw the data for institutional births and antenatal care of 4th and 5th rounds for India as a whole, then also for the states like Arunachal Pradesh, Jharkhand, Kerala, Nagaland, Tamil Nadu, and Uttar Pradesh. Here, and in table 7, we will see certain women's empowerment and social indicators. Here we will consider financial inclusion and menstrual hygiene have seen some of the most dramatic positive shifts over the last 5 years during the survey periods, indicating a rise in female autonomy and health awareness. So here in table 7, we also see women with bank account and hygienic menstrual protection, as recorded in National Family Health Survey 4th and 5th rounds. And we see here the data for India is on average as national data, and also for states like Bihar, Chhattisgarh, Haryana, Madhya Pradesh, and Tamil Nadu. And also we consider here the data of demographic and nutritional challenges. So while demographic indicators like sex ratio at birth have improved in several states, the prevalence of anemia has worsened nearly everywhere, representing a critical public health concern. And this we see in table 8. In table 8, we see sex ratio at birth and anemia in women in the age group of 15 to 49 for the states Delhi, Karnataka, Ladakh, Odisha, Uttarakhand, along with the Indian average. So what we see in these tables, 6 to 8. First, we see the leading progress. States like Tamil Nadu and Kerala continue to lead in maternal health, though Kerala experienced a slight dip in the percentage of women attending 4 ANC visits. But let us remember that the figure is already high in Kerala. And Delhi and Uttarakhand made remarkable strides in balancing the sex ratio at birth. Then rapid development. And we see that Uttar Pradesh and Arunachal Pradesh showed significant jump in institutional births, narrowing the gap with better performing southern states. And we also see the anemia crisis. The data confirms that anemia is a worsening epidemic. In states like Odisha, the prevalence among women increased by over 13 percentage points, even as other health indicators improved. So we come to the conclusion of this module. While India has made commendable progress in reducing maternal mortality and increasing institutional births, the reproductive health agenda remains incomplete. The persistent anemia crisis, the burden of female sanitation, and the systemic exclusion of unmarried women and gender diverse individuals indicate that a clinical approach alone is insufficient. Moving forward, India requires an intersectional reproductive justice framework that strengthens the public health sector, regulates the bargaining private sector, and dismantles the patriarchal norms that continue to limit women's agency over their own bodies. So with this, we come to the end of this module. And in the next module, we shall enter in the 11th week of the course. And in the next week, shall have two modules, two videos on gender in the global economy. Thank you.